Here we go.
All right. So I've already mentioned you in class, so this is Annette. I worked with her at hospice.
Hi, Annette.
Hi. Nice to meet you guys. So I started as an LPN in 1980 and got my RN in 1994. So about 35 years of nursing. And the bulk of my career was spent at the Minneapolis VA Medical Center, and now I do part-time home infusion nursing. So I've had a complex ileostomy history, and I kept kind of taking pictures of things when I was in the hospital, kind of kept a diary of what happened, and then shared that with Sean, and we thought probably be a good presentation for you guys. So let me get to this first slide. Okay, so in 2000, that's not a picture I took. I was asleep. Anyway, in 2005, I had a very, straightforward abdominal hysterectomy. But after surgery, I had some complications with bleeding. And I went into the clinic in the hospital. There was a medical clinic in the hospital. I went to see the doctor, and he said, we need to flush those clots. They were around the cervical cuff. So he said, we need to flush those clots out, and I'm going to use hydrogen peroxide. And the nurse part of me said, I'm not sure I'm comfortable with that, is what I told him. And he said, we do this all the time. So they advanced a Foley catheter in, and he took a 60 cc syringe of peroxide, flushed it in, and I felt immediate right referred shoulder pain. And I said, take it out, I'm in pain, I felt like I was gonna pass out. He goes, well, usually people are uncomfortable with this anyway, so just relax. The clinic was about to close for the afternoon, so they told me to stay there, and when I wanted to leave, to go out to my car. Well, what inevitably happened is there's an incision inside near the cervix. He pushed the catheter through into the peritoneal cavity. So he flushed peroxide through my whole abdominal cavity. So I went into shock in that clinic room, and everybody was gone. Nursing staff were gone. They didn't know I was still in there, but I couldn't get out of there because I passed out and I was on the floor. So eventually somebody heard me screaming down in that room, and they took me down to the emergency room and started working on me. But it took a long time for people to understand what was going on, and I couldn't advocate for myself. I kept saying in the emergency room, I have peroxide inside me. I knew what was wrong, but nobody could get it. So I went through the emergency room 6 hours with peroxide in my abdomen, nurses telling me, we can't give you pain medicine because we don't have an order right now. We have to wait for the doctor. My abdomen was on fire. It was the most horrible pain I've ever been through. But eventually, they did a CT scan, saw all the free air, and I was brought to surgery, GI, and OBGYN. Gynecology was there in the operating room, rinsing me and trying to get all that peroxide out. So there was a lot of copious amounts of gray foam in the abdomen that sat there. So now we'll bring us up to 2012. So what happened consequently, and I don't know for sure whether the peroxide caused this, but what happened, and one surgeon said to me, well, it certainly didn't help. It didn't help you out, with your small intestine, large intestine. But what I started to have trouble with is motility issues. I was taking at one time 15 Ducalox tablets a day to go to the bathroom. So motility was a huge problem for me, chronic constipation, and just, nauseated because everything was backing up. Absolutely could not, get that. And what would happen was, this would just get filled, and what happened was my large intestine was just like it became flaccid, and it lost the muscle tone. So the barium study showed that there was a significant delay in transit time, huge delay in transit time. Then they also found, so what I opted for is to have a temporary ileostomy. So when they got in there to do the temporary ileostomy, they found that the large intestine was slightly twisted. So that was removed, and it was decided to do a temporary ileostomy to take some of that, let me show you this here, sorry, I'm getting ahead of myself. To take some of that colon out, and then do the temporary ileostomy and see how I would do. So I've had both actually. Here's the loop ileostomy, and basically the small and large intestine is kind of halved. So what they do is when they want to reverse that, they just sew it together, drop it in. And then I have this now, the end ileostomy. Okay, so there's the picture of the loop ileostomy. So you have the large intestine, small intestine here. Generally, mucus just comes out of here, and then the liquid stool comes out of here. Now, some people will keep that. They'll just keep that and not have an end ileostomy, but it's very hard to fit an appliance around that. So I opted to have, just the end ileostomy done eventually. Okay, so after a period of time of sitting with that temporary ileostomy, I obviously did very well. They wanted to reverse it. So about a year went by that I had the temporary ileostomy, living with that and just seeing how I would do. And then in 2013, they decided to reverse it. So this is the way you look post-op when they do that. This is all supposed to granulate in eventually. Sutures around there, and there's actually a hole in there. So that's all supposed to granulate in. But what happened to me was I ended up with the sutures coming apart, and then it didn't granulate. Actually, that is a little blurry. Here's what happened. So this wound took about 3 months to heal. I had to pack it way in here. It was pretty deep. And that eventually did heal. You can see all the redness around it. So that took quite a long time to heal. So then after I had that reversed, unfortunately, I ended up with the same motility problems again. So, and I was just in agony because I couldn't go to the bathroom. And when you take Dupalox tabs to that degree, you're taking them, then you're incontinent because it's like this wave coming, and then pretty soon you're having liquid stools and you're incontinent because you're trying to get that stool out. So it was really miserable. So I decided at that point, and the surgeon decided to have a permanent ileostomy. So there's another picture of it right here. Now I still have some of my large colon in there. It's just sitting in there. And then it's disconnected, of course. All right, so then I decided to have the permanent ileostomy. So you guys, what do you think, when you're first looking at that, what do you think's wrong with that picture? Looks dusky, doesn't it?
Yeah.
Yeah. So that was my first surgery. So when I was in the hospital, I said, I don't know, but it looks dusky to me. I'm not real okay with it. So the doctor said, well, they can look a little dusky. And I took that picture to record it, because I wanted to look at that later. So then, consequently, what happened 2 weeks later, this happened. nobody listened to me. And I actually, when it turned this way, I actually called the clinic. Well, we don't know if we can see you. I said, you know, it's pretty black. We don't know, we can't get you until next week. I'm like, you know what? I think I need to be seen for this. People just not getting it that there was a problem. So then I had emergency surgery that day. And what happened was she burned off the necrotic tissue and tried to save that stoma. But what happened was this, it receded in. And what I ended up doing, you guys, is this is what I lived with for several months, was putting a catheter in and removing the stool myself. So that went on for quite a few months where it just would not drain. Sometimes it would drain. I was having to push on it to get the stool out, and it's liquid, and it just was stopping. So I ended up with a couple of bowel obstructions with that being receded like that. And it's very hard to get, and you can see, you guys, it's real common to have a fungus around here. So I had kind of a fungus developing. And then your appliance, sometimes when it recedes like that, the stool just leaks out. And it's hard to get an appliance to fit. So consequently, because it would drain, had projectile vomiting in the hospital for, and I would keep going to the clinic. The doctor's like, she puts her pinky in there and she goes, well, it's not obstructed. Just like, come on. I have to remove the stool with the catheter. It's obstructing. So finally they did a barium study and they could see that the barium stopped when it got to that point. It wouldn't go through. So then they decided to do, there's my dog. When I got, actually I rescued her when I was going through all this because I was so depressed. So she has one lung. She came from puppy mill and was kicked. And her and I healed together. So, I had to include my dog Jeannie. Okay, so now here we had the neck surgery. They decided finally that, we gotta redo this. It's not working out. So, you can see the difference here. Look at that nice, red, beefy red. Now, right after surgery, it's really swollen. There's all the sutures there, and you can notice there's an infected suture here starting. And you kind of get a fungus that develops around. I had to work with that for quite a while. Now, these next slides are going to show you. So the stoma starts to change. All that tissue starts to slough. And so there's a whole healing process that goes on even after you go home. There it is at home. So you can see that it's shrinking. This is sloughing. So it starts to change and become more normal.
So this is a normal process.
Yeah, that's a normal process. Yep. Yep, so there it is again. And had an infected suture here that I had to heal and pack a little bit. But there's a whole healing process with the sutures sort of dissolving. And you can see that it's getting smaller like it should be. Okay, so want to get onto this. So in the hospital, I had problems with edema in my lower legs. This is third day post-op. So I'm trying to find that page, sorry. Third day post-op, I'm having more pain when you should have less pain. My SATs were dropping. Temperature was 99, going up to 103. So, and my incentive spirometry dropped 1,000 points. So now during this time, nurses are coming in, they're doing vital signs, and they're switching equipment. So they put the pulse ox on me, 89, they run out and get another piece of equipment. They get a temperature, it's 99, well, we'll check it later. I'm having more pain. Well, you know, you can get some more pain medication in a few hours. You know, when patients have pain and it's unresolved, we need to call the doctor and get their pain under control, which is really important. Because what happened was I couldn't breathe. I was not breathing. You can see right here, when you have an incentive spirometry that's dropped 1,000 points and your sats are dropped, okay, the patient isn't breathing very well. And I was walking to the bathroom and bent over because I had so much pain, and the nurse would say, well, stand up straight. And I'm like, I can't, I'm in so much pain. So this went on for about 15 hours of, well, and look at all this edema on the lower legs. I mean, I didn't understand what was going on. I'm like, why do I have all this swelling? Well, everybody's busy, nobody can answer that question. So then I went into, interventional radiology one night late. I had a huge abdominal abscess. So it kind of explains all those things. But what happened was I got so sick I couldn't advocate for myself. You know, I'm a nurse, I know that there was something wrong, but nobody was quite listening to me. And so nobody was kind of investigating edema. So that was from infection. You know, the incentive spirometry going down, the pain issues, the fever, O2 sats low. When you put that all together, that makes sense. But unfortunately, I lived with a lot of pain and a lot of distress for quite a long time before somebody decided to do something. That's why it's so important, you guys as nurses, to advocate for your patients. Don't be afraid to call that doctor and say, hey, this is what I'm seeing. This is what I'm seeing, I'm concerned about it. And if you're seeing signs, because these things are subtle. You know, my SATs were 89%, 90, 89, I don't have respiratory disease, so watch the movement. Then I went down to 87. Well, there's something wrong. So it's very important to do that. And we had a lot of nurses that didn't want to call and deal with pain. You know, we're not the drug police when you're taking care of patients. So it's important to keep on top of patients' pain. I have a lot of trouble with that with nurses at the hospital. So anyway, after interventional radiology went in, they took a great big rod, looks like a harpoon, and it's got a corkscrew on the end of it. They put that right into your abdomen and screw it into the abscess. Very painful. When I saw that, I said, oh no, you're not doing that to me. Yeah, we are. So I had this drained for like about 5 days. Oh, one thing I was going to talk about, abdominal binders are very helpful with people with an ileostomy, especially all the surgery that I had. Now, you can't put it super tight because, you know, you need the ileostomy to drain. But I wore this, you guys, for about a year till my abdominal muscles were feeling better. So that's a real benefit to people, and not everybody thinks about it. Okay, so there I am. And, you know, what I wanted to talk about too today is emotional aspects. You know, some patients will come in and they're very young, or they have a diagnosis of cancer, and they find out that they're going to be living with an ileostomy or even a colostomy. So it's very important, even though the patient looks this sick, to get them hands-on with changing that bag. You know, usually in most hospitals you'll have a stoma nurse that will come up and kind of handle the particulars, but the stoma nurse isn't there all the time. So it's going to be very important that you have them work with that equipment, even if they don't want to, even if they feel sick. The sooner you get them hands-on with it, the better. Because, as I showed you, there's a whole healing process that goes on with that stoma at home, and it has to be taken care of properly, or they're going to end up with an infection or a bunch of, you know, skin issues that they can't deal with. So, and if you see a patient that won't deal with it, doesn't want to, you know, you're noticing that they're real depressed, that need to to get somebody to come talk to them. And there is an ileostomy support groups everywhere too. I mean, even you could get somebody to come in to talk to them. It's very, very important. And you guys are gonna see the first signs of that. Okay, so let's talk about diet. So diet is really individual to the patient. You know, patients with ileostomy, the biggest cardinal rule is that they need to be on a low residue, low fiber diet. Because where does fiber digestion take place? Large intestine, right? So, you know, they can't be eating a bunch of raw vegetables because they're gonna obstruct. So basically, and so a big problem with ileostomy, what do you think a big problem is with ileostomy as far as fluid status is? Dehydration, yep. So I'm always bringing fluids with me all day because you're losing a lot of your fluids constantly. So that's very important to be drinking a lot. And so they need to avoid eating seeds, popcorn, nuts, raw vegetables, and chew food well. You may need a grinder to grind up your food, possibly. You know, certainly steak isn't a good choice, you know. So their diet has to change. Your meds may need to be crushed. So that's what I've had to do. Carbohydrates have a rapid transit. I can eat some carbohydrates and it's dumping in the bag 20 minutes later. Protein, like eggs, which I eat a lot of, I don't have digestion, or I don't have that empty until morning. If I eat it in the evening, I don't have empty until morning. Now, one thing about me is my diet is pretty restricted because I have motility issues in my small bowel as well. So I had about 4 small bowel obstructions. And I got one just eating cooked ramen noodles. I got obstructed. So I'm very careful about what I eat and really limited as far as diet. I can't be eating pizza. Now, some ileostomy patients, if they chew it up good, they'll be able to eat that. But I can't take that chance. So I'm very careful about that. So ileostomy patients need to try new foods one at a time. Weight loss can be a problem. Because when you first get an ileostomy, I don't know what this is, but after surgery, if I ate tomato soup, I was emptying tomato soup later. So your appetite, when you're starting to work with that, you lose your appetite. So a lot of patients go through huge weight loss with this surgery. And draining the bag, they have to get used to that, and it affects your appetite a lot. I eat about 1 meal a day in the evening, because I'm out working during the day. One of the problems with ileostomy that you guys, because you're sitting, that I can't do, gas comes out of here. The minute you swallow food, this starts blowing gas. And I was reading a blog online. I was kind of looking up, what do you do about that? Because, you know, you're in a staff meeting. This thing is loud. And it's embarrassing. It's embarrassing for people. And so there's a lot of ideas people came up with. But it's frustrating for people. So a lot of people like me will drink fluids all day and then they eat 1 meal when they get home, and that's basically what I do. That's how I've been able to avoid it. Now, it still will make some racket, so I put a couple of washcloths in here and cinch up my belt when I see a patient, because I don't want that coming out. There's a lot of different ideas. I was trying to invent something. So I had an abdominal binder and I tried like a plastic cap, you know, a plastic lid. Well, that is not a sound barrier. That made it loud. I mean, I could hear it all over the room. I'm like, okay, that's not a good solution. Try plan B. So then I used a piece of foam, and then the foam actually pushed on the stoma too much. So I ended up using washcloths. So that, you know, everybody, they do have something online called the stoma stifler. And it's the most unbelievable. It's like $200. it's got straps everywhere and plastic on the top and something you pump up so you have to carry the ball in your pocket. And I'm just like, so I just decided to go with the washcloth. But I don't think we have a good remedy for that. Okay, let's move on because I'm going to get through this with you guys. Okay, so lots of equipment, you guys, available out there. Lots of equipment. So one thing that's nice is when patients are in the hospital, I don't know how this happens, but their name goes into something from the hospital, then they get samples like crazy. And encourage patients to go online and look at what Hollister has. Look at what all the companies have to pick what they, I was taking care of a patient the other day and doing a infusion. And he has an ileostomy, so we got to talking about that. He had all the wrong equipment. Well, he went with the nurse who dropped off what was in the closet to him that day, and he just kept reordering it. And so he had all the wrong stuff, wrong equipment, so I got to talk to him about that. Now, a month's supply of equipment for me, $600 for my, so it's very expensive. One thing that's important to you guys, when patients, very important when patients have an ileostomy, carry your equipment with you. Because I've seen patients that forget their equipment, they end up in the hospital. They end up using the equipment that the hospital has and they get broken down like crazy because their skin is not used to it. So it's very important. So I have packed in my car several changes of equipment, pants. You have to have that in your vehicle. And if I go to the hospital, the first thing I do is start packing equipment, my own stuff. Because if I go to the hospital, I want to have my own stuff to use. So that's important. Okay, so these are, these are more for colostomies. You can use them for an ileostomy, but I don't. Because this clip, you end up having to clean this plastic off and it's dripping. I mean, some people still use it, but this is like a one piece where the flange is attached to the bag. So when you change it, you'll change the whole thing. This is an older bag with a Karaya ring, and that sort of swells up and becomes like a jelly around the stoma. Okay, so here's another style. Now there's Velcro here and these roll up. These are a little difficult with ileostomies because, again, the liquid stool comes down in here, so you have to find a way to get that out and wipe it off, and then, you roll it up and it's kind of in there, and I don't know. I'm sure it works for some people. I didn't really care for it too much. There's a vent at the top on that one to keep the bag collapsed, which is kind of handy. And this is a soft skin, which is a lighter adhesive for patients that have skin problems. So there's a lot out there. I don't think I even have 10% of what they make now. So this is a two-piece system, which is what I use. You'll see when we go to the lab. I like this because you just cap it, and you can also put a night bag on here. So what I did was, when I had shoulder surgery and I couldn't empty my bag, I put a night bag on and got to have all that just drain into the night bag and not have to worry about it. Now, I didn't look so good answering the door with a bag of poop and, And then this flange, these flanges come in, some are all adhesive, some have a tape border. There's so many different kinds. You can get different sizes of these rings, larger ones. And of course, this would be strictly for a urostomy or an ileostomy. You wouldn't be able to use that for a colostomy. Okay, there's all the different kinds of flanges, you guys. You know that stoma I saw you that was receded? Yeah. This convex flange is what you use for that. Pushes the skin in to allow that to drain. So there's all different kinds. I mean, there's just so many different kinds that you can get. And then teaching the patient how to cut that flange is important to get it as close to the stoma as you can. There's the two different high output bags. You can get different sizes to accommodate. There's so many different styles now out there. The biggest thing you need to tell the patient is to investigate and try many different things. So again, it's very important to cut that flange as close to the stoma as you can. And then this would be the wrong way, where you have a bunch of open skin there that's going to get broken down. Now, there's stoma paste. So there's Coria powder. So what patients do is they'll put a paste around that stoma, so even if they don't cut it perfectly, they're still going to have protection on that skin. I use this barrier ring and just push it down, and then this for sure seals around the stoma. And there's a lot of different kinds of barrier rings you can get. Now, remember I talked about that fungus around the stoma. Very common. All you use is Desenex foot powder for that. And that was what my stoma nurse told me, and I have a bunch of it at home. And just lightly sprinkle that on, and that will help take care of the fungus. There's adhesive remover you can use. You have to be careful with that because you can't get the appliance to stick if you use it too much. Barrier film is okay, but again, be careful with it because the patient won't be able to get their appliance off if they use too much of it. I didn't tend to use the barrier film because it just, it would get too difficult to remove the appliance. So if patients have sensitive skin, that might not be a good route to go. Okay, this is what's important. Ileostomy stool. It's the worst smell of your life. I mean, it is. I was going to have you guys experience it this morning and leave the deodorant out, but I don't want anybody passing out. But honestly, that's where the beginning of digestion is. You guys, it's a terrible smell. So what I encourage patients to do, and what I've done myself, is there's a product called M9, which dissolves the stool, actually breaks down the stool, and it absolutely can't smell anything if you use this, and you only need a few drops. This is a deodorant you can put in the bag too. This is very important because I met with a patient whose wife was just going crazy because the guy comes to the dinner table and she could smell the ileostomy stuff all the way to the table, and she's like, what can he do about that? And I said, well, he just needs to use M9. And he had a bottle of it that he got from the hospital. So, it's very important. So I always use M9. I order it online. And I just, like you're in a public bathroom or you're at a restaurant. You don't want that odor, and it really does carry. Now, my teenage boys, when I had the surgery done, I would purposely not flush the toilet because they're pounding on the door, get out, get out, get out, get out. So I emptied it, walked out. There you go. Mom, gross, oh my God. So good. When I was at the hospital, and they were at school, and I was having something done, I'd take pictures of my bag full and send it to them. Honey. Love doing that. That was fun. So the night bag is really helpful, especially with people who are having surgery, where, you got to think about that. I mean, I had a surgery on the shoulder. How am I going to change this appliance? Or empty it. So night bag works really well with that high output bag. Okay, so the one thing to remember about ileostomies is it's unpredictable. You always got to have something with you for that, because I'll get out of the tub, and if I don't have something, over that, you're just going to be full of stool. So it's very important that people understand the unpredictability of it, because you could just end up with, you know, your pants and everything full of stool. So you always have to keep something handy to keep that covered. This is just to talk about, you know, the fact that you can have a normal life. You know, yes, it's, you can still go rock climbing, you can still do, she probably has her bag with her, you know, supply with her, you do have to carry extra things with you, but it doesn't mean that you can't be active and jog and climb rocks and stuff like that. So that's the point of that picture. Okay, so you guys, should we do question? Oh, are we? Oh, we gotta do that, don't we?
We have a few minutes. We're okay to go right up to 10.
Do you guys have any questions, or do you want to wait till then? Or?
What about caffeine? What happens?
Caffeine. Okay, so caffeine. You know, I love caffeine, and like all of you, and they don't want you to drink it because there's acid. And I'm like, oh, for crying out loud, how much acid can be in caffeine? So when I drink a cup of coffee, this bag empties with bile twice, fills up with bile from 1 cup of coffee. So, yeah.
You said your diet is really limited, so do you have to take quite a lot of like liquid vitamins and that sort of thing?
No, I don't. What I've been doing is getting my labs checked, and I checked with Sean about that, and there's some particular labs that I should be checking on, like total protein, albumin. So I'm about to get those done. I've lost about 60 pounds since this whole thing started.
But now you're maintaining it?
Yeah, and every time I do get my chemistries checked, they're okay, but I think I need to do a little more evaluation about protein, because I probably am not getting enough protein. I don't know. Here's my diet. Okay, I ate squash last fall. Okay, squash went through, worked perfect. So I ate squash all winter. I just cooked it myself, and every night for 6 months, I've been eating squash. I love it. So that's my diet. Then I got a little sick of squash after 6 months. So now I'm on to eggs. I tried 1 egg with a little toast, went through. Now I've got a ton of eggs, and I'm gonna eat those for the next 4 months. Eggs in the evening. So I don't have a lot of variety in my diet, but because I'm frightened to eat other stuff, I'm just very careful. Some things give me indigestion, you know, so I'm just careful about that. Yeah.
Can you add like seasoning to your
Yeah,
foods,
I
or
do.
does that vegetable
Yeah,
at all?
well, salt, but not pepper. Yeah, I used to love ice cream. For some reason, I have a stomach ache the next day after ice cream. I don't know what that's from. Yeah, I'm sorry. You were. I'm sorry. Go ahead.
So after the final successful surgery, how long did it take for that stoma to slop and recede in size and heal?
Probably about a month or 2.
Okay.
Yeah, depending on whether, now if I got like the second time I did okay, but if the first time I had a fungus and stuff around there, so that delayed it more. But it should start to morph or change into a regular stoma over 1 to 2 months.
When you only eat once a day, do you get hungry?
No,
Not at all.
nope, I just drink fluids all day and eat in the evening. I might get a little hungry in the evening, you know, but I think my stomach is shrunk up, so.
And so fluids, you're just drinking water, or are you putting?
I have some juice. I can't drink, now, the juice nowadays, you guys, when you look at the bottle, it says 5% juice. Well, that works good for me, because if I have 100% juice, I'm burping, I'm gassy, all that kind of stuff. So I'll get something that has 5% juice and drink that all day.
And that
Yep.
mixed in.
In the red.
I was just curious, do you know what your daily calories are, or what you get with that 1 meal in calorie count? Are you near 800 calories? It sounds like you're probably around
I'm probably
6.
around 1,000 or 1,200 maybe.
With 1 meal?
One meal.
No, I drink something. No, then I like to have, I mix up a concoction each each day that gives me some calories. I like whipped cream. I can't have ice cream because it's too rich for me. So I go down to Super America, just kind of have the whipped cream bar, you know, with chocolate. So I fill up a whole container, don't tell on me, whole container of whipped cream. I put a bunch of caramel in there, a bunch of chocolate, and then I eat it in the evening, stir it up, and I drink that. And then I have some protein drink I drink too. So, for some reason the whipped cream doesn't irritate my stomach as much. Yep.
So is it an issue to like still kind of monitor and get a colonoscopy every now and then, just kind of monitor how
Yes,
that's doing?
that's true. I actually have to start thinking about that again. But now what happens, yes, I do have to have a colonoscopy. And also they did, they did that actually with my last surgery. They went in and checked all of that, so I'm kind of good to go, but I have to call again to see when that will be done. Now, because I have some of my colon there, that fills up with mucus, lots of mucus. So I get in the morning cramping like I have to poop. And so sometimes it's severe, and it builds up over 1 month where I gotta stay on the toilet for like about an hour getting rid of mucus. So you just feel like, okay, I gotta have a bowel movement, and you have to sit on the toilet because you get cramping. It just happens every morning for a little period of time.
How much large bowel is left?
Probably maybe half.
The descending, obviously.
Yes,
Okay.
yes. And so some patients will use fleet enemas to get rid of that mucus because it builds up, so they'll kind of cleanse out like a fleet enema.
All right, we can move out and more questions in the lab.